Good evening, everyone. I am Insiyyah Patanwala, and I am one of the complex gynecologic surgeons at the University of Chicago Medical Center, and I am the director of the Pelvic Pain Center. And today, during evening rounds, I am here to talk to all of you about chronic pelvic pain. So, of course, at the University of Chicago, we have multiple missions and values, which we, of course, as part of evening rounds, hope to essentially kind of embody, and also we want us to all to grow together, make sure that we're understanding what we are working with and who we are working with. And so I know that people are curious about pelvic pain, and I hope that I can answer some of your questions today. So first off, I have no financial disclosures. There are very few treatments for chronic pelvic pain. It's a very understudied area. And so a lot of the therapies that I do talk about, though, are considered off-label use and don't have FDA approval specifically for pelvic pain. So the objectives of today's talk are to understand the causes of pelvic pain. I know that when we think of pelvic pain, a lot of us think endometriosis, fibroids, but today I'm not here to talk about that. I'm here to talk about kind of other causes that don't always fit into what we typically think of as gynecologic causes of pain. We will review medical and procedural therapies, and then we'll also figure out different ways that we can help each other and our patients. So first off, I'd like to kind of go over, normally I kind of have, people kind of call out what are some gynecologic and non-gynecologic causes of pain. But since I know that we're all muted on today's talk, I'm just going to go ahead and do that for us. Our common gynecologic causes, so like I already said, fibroids, endometriosis, adenomyosis, which is on the spectrum of endometriosis, ovarian cysts, and then pelvic floor muscle spasm, which is essentially one of the big, topics I'll be talking about today. Vulvodynia, which is essentially pain of the vulvar area that is not, that we can't explain with, any of our tests, essentially. Pudendal neuralgia, primary dysmenorrhea, which is also painful periods without a known cause, pelvic adhesions or scar tissue, pelvic organ prolapse, pelvic inflammatory disease, and pelvic congestion syndrome. And then very rarely gynecologic malignancy. And then, of course, there are also causes of pain that are not related to the GYN organs. That includes irritable bowel syndrome, inflammatory bowel diseases such as Crohn's and ulcerative colitis, interstitial cystitis, and painful bladder syndrome, which is something that I also treat, recurrent urinary tract infections, and musculoskeletal dysfunction, which I also treat, especially when it's affecting the pelvic floor. And then a lot of our pain pathologies also tend to run together. So a lot of patients who have endometriosis and pelvic pain and pelvic floor muscle spasm will also sometimes have interstitial cystitis, IBS, fibromyalgia. So a lot of times it's hard to tell what is causing what. And then, of course, depression, anxiety, PTSD is also a big player in pain, and sometimes it causes pain and sometimes it is caused by pain. And then, of course, rarely there are certain cancers that can cause chronic pelvic pain. So in general, chronic pelvic pain affects about a quarter of the female population. ACOG defines it as 6 months duration, where it is perception of pain that's coming from the pelvic organs. And the reason that I highlighted perceived is because a lot of times patients will say, well, the pain is coming from my ovaries. And me and you know that it's probably not their ovaries, but that is what the patient feels. And so that would still come under the guise of chronic pelvic pain. The pain can be constant, it can be cyclical, it can be only associated with a specific activity such as sex, or sitting at a desk for too long. It can also be in multiple locations or just one location. And sometimes it might radiate to the back or down the leg. And it doesn't have to be associated with the menstrual cycle. So oftentimes we think of endometriosis, fibroids. The pain is always worse with the menstrual cycle or ovulation, but that's not necessarily the case with all pelvic pain. And kind of the big takeaway is that chronic pelvic pain is not caused by one disease. It can have multiple different factors. And oftentimes, if you read my notes, I'll say multifactorial pain caused by this, and this. And while it can be caused initially by endometriosis or fibroids or, even a sexually transmitted infection, later on when it has progressed, it's not only caused by those things. So there is a lot to cover in this topic, and I could probably talk to you all for hours, but I only have, this hour. And so we are going to be focusing on pelvic floor muscle spasms or vaginismus, which it also causes oftentimes pain with intercourse, pudendal neuralgia, vulvodynia, and painful bladder syndrome or interstitial cystitis. So one thing I want to kind of talk about before, we kind of delve into each of these individual categories is that a lot of patients who experience pain, especially pelvic pain, have a history of trauma or abuse. And so we have to be very cognizant of that when we're talking to our patients, when we're examining our patients. And so different patients may require different things. They may not want to do an exam and on their first visit with us, and that's okay. Patients should be able to control the pace of their visits. We as providers should be able to explain the reason for any tests or examinations we need to do. And we should always obtain clear consent before we do any examinations or if we ask any intrusive questions. So for example, I'll oftentimes ask about a sexual history, abuse history, and I usually will preface the questions by saying, I ask these questions of all of my patients who experience pelvic pain. I just want you to be prepared that some of these questions may be very personal. And then they have the chance at that time to say, oh, I don't want to answer any of these types of questions or something like that. And then the same with the exam. I will kind of check in with patients throughout their examination to make sure that they are okay with what the next step is and that they know what the next step is. And so all of of course, whenever, we are seeing any of our patients, we're going to get a detailed history. And so essentially the history that I get for almost all of those pelvic pain kind of topics that we're talking about today is almost always the same. So I'm always going to ask about kind of the onset, the palliation and provocation of their pain, the quality, whether it radiates, kind of what helps it, what doesn't help it. And then, of course, we'll go over allergies and treatments. But things that I kind of want to highlight is that of course, like we discussed, we talk about history of abuse. We talk about history of OB trauma. So, a lot of times patients will start having pain with intercourse or chronic pelvic pain or hip pain after pregnancy. And so it's important to know kind of how their pregnancy went, what kind of tear they had, whether they had a vacuum or forceps delivery. Like I said before, a lot of these pain syndromes kind of run together. So it's important to know if a patient is experiencing other pain in other areas. And then depression, anxiety, lack of sleep, those can all make pain worse. They can also be caused by pain. And then I do ask a lot of questions about kind of, falls and fractures, whether, they have chronic back pain, what type of exercise they do, whether they have pain with heavy lifting, biking and spinning, especially can sometimes put patients at increased risk of pudendal neuralgia or vaginal pain. Weightlifting can put patients at increased risk of hernias. So these are all, things that are important that we don't necessarily always ask as part of a typical gynecologic examination. So first, we'll start with pelvic floor muscle spasms, also known as myofascial pain syndrome. Okay. So, kind of the hallmark signs and symptoms, pain with intercourse, especially right upon entry. That's also sometimes called vaginismus. Pain with tampon insertion, like pain that worsens with certain types of activities, and then pain that radiates into the back or legs, or if pain starts in the back and then kind of radiates into their pelvis, that's also usually a sign of musculoskeletal dysfunction. And then if the pain started after a traumatic incident. So, of course, we talked about the detailed history, and then we'll do a physical exam that includes a very thorough musculoskeletal evaluation. So for those of you who have been in clinic with me and have been in the appointments with me, know that I oftentimes will kind of watch the way that a patient walks around the room, how they sit, and then I will assess their spine and their sacroiliac joints when they sit on the table. That's usually the first part of the exam that I do. Then I'll have them lay back and I'll feel kind of throughout their abdomen, but also, check their pubic symphysis and their superior iliac spine. And then I'll also do range of motion testing, especially to kind of check their lower extremities and their hip function. I would say about kind of once a month, I do diagnose somebody with a hip labral tear that they have been told is due to, their uterus or their ovaries, but it's actually hip dysfunction. And then, of course, we'll do, a pelvic floor exam. And so I'm testing multiple different muscles, and that includes, the bulbocavernosus muscle, which is right kind of towards the entrance of the vagina. And then deeper in the vagina, the kind of main muscular group that I'm looking at is the levator ani muscle. And then another muscle group that is not pictured in this picture is the obturator internus, which is oftentimes implicated. And that is kind of what you see depicted here. Now, I don't make patients cross their legs while I'm examining them, but I will oftentimes, when I'm kind of palpating the obturator internus muscle, which is usually kind of at 2 o'clock and 10 o'clock in the vagina, I will ask them to kind of push their leg in or out to see if that triggers any pain. And you do have to kind of palpate each muscle with a certain amount of pressure. It can't be too light because then patients really can't tell the difference of whether this is just kind of whether this is pressure or pain. But it has to be a good amount of pressure. And most patients will say like, oh, that feels weird. It feels like a lot of pressure. And then I usually tell them, well, pressure is normal, but pain is not. And they're able to tell the difference between those two. And then a lot of patients have high tone pelvic floor dysfunction because they have trouble relaxing their pelvic floor muscle. And so when you ask them to squeeze around your finger, it gives you an idea of whether their muscles are so contracted that they can't squeeze at all. Or sometimes it'll also tell you that their muscles are so weak that they can't squeeze at all. So there's a difference in kind of the laxity of the tissue that you feel when they try to do that. And then I always do the palpation of the muscles before I do the speculum exam, because the speculum exam for many patients can, one, be very triggering. Two, it's also usually more wide than a single digit exam. And so I like to make sure that they can handle a single digit exam before I do a speculum exam, so that, they don't feel sensitized. So as many of you know, I have a pelvic floor physical therapist in the clinic with me. And I'm very lucky to have her because I would say almost 50 to 75% of my patients need to see her. Multiple studies have shown that PT is kind of time and again the one thing that has been shown to help with high tone pelvic floor dysfunction, pain with intercourse, and it's like there are a lot of other things that I do in clinic that we'll go over, but in general, physical therapy is the one thing that has been shown to actually help the most. And so one of the biggest barriers, though, to physical therapy is, one, the idea of it. So sometimes Patients are shocked that they can have a pelvic floor physical therapist, that there's a physical therapist that will actually kind of work on their vaginal muscles. And so I think it's nice to have a physical therapist in the clinic with us so that they can meet them right away. There's no kind of barrier to kind of education about exactly what the pelvic floor physical therapist does. And then also scheduling those appointments becomes easier as well. So I'm very, very thankful that I have our PT support. And hopefully our patients appreciate it too. The one thing about kind of pain with intercourse is that when it causes pelvic floor muscle spasms, it's really important that while you're undergoing the treatment to advise patients to try to not have intercourse while they're undergoing treatment. The reason for that is that, one, the mind associates sex with pain, and so it will automatically, if they continue to try to have intercourse while they're undergoing therapy, it can cause those muscles to spasm even more because, it hasn't broken that relationship in the mind that, sex equals pain. So when patients are going through physical therapy, everything is like very graduated. And so then there's a chance for patients to kind of be desensitized to that idea. And so I usually ask patients if they can to avoid intercourse until they're cleared by PT. The other big thing for pelvic floor hypertonicity is that I usually tell patients to stop doing Kegels. So I think, 10 to 15 years ago, Kegels became very, very popular. Everybody wanted to do them to prevent pelvic floor prolapse, urinary incontinence, and Kegels are definitely still important for the right population. But for patients who are experiencing pelvic pain, we actually need their muscles to become less tight. And so doing Kegels is counterproductive. And then other therapies that I do utilize but don't have, as much evidence behind them includes vaginal dilator therapy. And we actually have dilators available in the clinic to give patients. But the kind that we usually recommend come with a set where they start with like something very small, and then they essentially, the instructions are to place it into the vagina as deep as they can with only a little bit of discomfort, and then to try to hold it in place for about 30 minutes at a time. And if they do that every other day, then ideally they'll be able to kind of move through the dilators to the size that they need. And then, for some patients, they can't tolerate physical therapy or dilator therapy because their muscles are so tight. And so for those cases or where we need some extra relaxation, we can also prescribe vaginal suppositories. So this is off-label use, but you can prescribe vaginal diazepam suppositories or vaginal baclofen suppositories. I usually order them through a compounding pharmacy and instruct patients to use them about an hour prior to physical therapy, dilator use, or intercourse. For patients who have kind of pelvic pain plus pain in other locations, such as their back, then I can also prescribe systemic muscle relaxants. So those include things like cyclobenzaprine, tizanidine, baclofen. But the issue with those is that they can make you very tired. And so I do have to warn patients that, you might have pain relief, but then you might also feel more tired. And then there are neuromodulators such as gabapentin, pregabalin. We can use those to decrease essentially sensitization. And then the other, thing that you guys oftentimes see me do in clinic are trigger point injections. And trigger point injections are the ones that I do are typically with local anesthetic. I use a mixture of lidocaine and bupivacaine. And the point of trigger point injections is not that I think that the numbing medication is going to last them weeks and weeks. It's more that the numbing medication might help decrease some of the sensitization to break that cycle of central sensitization with the brain. But the other thing is that we think that the fluid itself, not necessarily the medication, but the fluid kind of helps relax the muscle fibers so that then they are able to kind of go into a more quiescent state. Physical therapy is a little bit more effective. And then hopefully, eventually they won't need these injections. For patients where the injections work, I usually tell patients that the local anesthetic injections work somewhere between 6 to 12 weeks. I've had patients where I do one set of injections and then their pain is better for, months and months and months, or they feel like they're cured. But then I do have some patients who come on a regular basis every 4 to 6 weeks for injection. So everybody's response is very different. For patients who have a short response to the injections, we could consider giving them Botox injections. But there's limited evidence for it. And so the biggest kind of barrier is also that insurance won't always cover it. But it is something that we can consider to prolong the effects of injections. So this algorithm was actually printed in the Green Journal in 2024. Our own Dr. Kenton helped create this algorithm. And so it's a nice overview of, kind of different therapies that we can start. And you'll see kind of at the top are kind of yoga, stretching, behavioral therapies, or like, bowel and bladder habits, pelvic floor, physical therapy. And then if if physical therapy for anywhere between 8 to 12 weeks doesn't work, then that's kind of where we kind of start considering all these other medications. And then sacral neuromodulation is something that we usually kind of save as a last resort. It's something that sometimes our urogynecologists complete or anesthesia pain colleagues complete for essentially refractory pelvic pain. So now the next topic I'll be covering is pudendal neuralgia. So pudendal neuralgia is defined by Nance criteria. And in general, it's pain in the area innervated by the pudendal nerve extending from the anus to the clitoris. So a lot of patients will say that they have pain that seems like it's spreading from the vagina and it's going into their buttocks region. They will also say that their pain is more severe when sitting. Oftentimes the story that you hear is that on long car rides, I feel like I'm in horrible pain. When I have to take a trip on the plane, I feel like I can't sit. Those are kind of the types of scenarios where we suspect this. There's usually no, sensory impairment. So meaning that, like, if I were to do an exam and ask a patient, like, do you feel this or this? They would probably say that everything feels normal to them. It's just that they have pain in that area. And then the pain is usually relieved by a pudendal nerve block, which is another thing I often do in my clinic. So what causes pudendal neuralgia? So in general, there are different things. So compression is probably one of the most common things. Oops, sorry about that. So compression is one of the most common things. And then entrapment, meaning that it's stuck in scar tissue or sometimes within muscle, can sometimes happen as well. Sometimes you can get a stretch injury. A lot of these injuries you actually can see with childbirth. Transection of the pudendal nerve is very, very rare, and that's not usually a common thing. So how do we treat it? So once again, physical therapy considered first-line treatment because
Dr. Patanwala, your slides are out of slideshow.
Oh. Are you seeing? I think you're seeing my other screen for some reason. All right. Does that look any different?
No.
we can see where you are now. You're back to your slide, but you are in, I think, presenter mode, so you might need to flip your screen again.
It's so odd, I'm still on the same screen, but okay, give me 1 second.
All set.
Sorry, did that change?
Yes.
Okay, all right. All right, sorry about that. So as far as treatment for pudendal neuralgia, so I was saying that physical therapy is still considered first line treatment. Oftentimes, if you have tightened muscles that are, close to essentially the pudendal nerve, then relaxing those muscles will help decrease the feelings of pudendal neuralgia. Other things that we oftentimes will use are also neuromodulators. So essentially nerve medications that includes gabapentin, pregabalin, tricyclic antidepressants such as amitriptyline or nortriptyline. You can also try muscle relaxants in this case as well, especially if we think it's due to tightened pelvic floor muscles. But a pudendal nerve block is considered both diagnostic and therapeutic. So if you do a pudendal nerve block and the pain resolves, then you kind of have an answer. And so a lot of times we will, a lot of patients, even though they don't know if they want pudendal nerve blocks kind of as their treatment long term, they do want to get it done at least once just so that they can figure out if it helps with their pain. And then for the patients where they do respond to pudendal nerve blocks, but the blocks wear off after, 3 to 4 months, we can consider cryoablation of the pudendal nerve. And depending on where the practice is, that can either be done by anesthesia pain or by interventional radiology. And then if a patient has severe pudendal neuralgia and it seems like on imaging there's entrapment of the nerve, they can undergo a surgical nerve release. There are a few kind of neuropelviologist surgeons who will do these that we can refer to kind of throughout the country and in Canada. So there are different ways to do a pudendal nerve block, which I have depicted here. So kind of in that upper left corner is what I do in clinic. So that is, as you guys can see, the pudendal nerve block needle that comes in the tray that we use. And essentially I'm feeling for the ischial spine, and then I am injecting essentially 1 centimeter medial and inferior to that spine to target this pudendal nerve. Okay, and patients usually tolerate this pretty well in the clinic. I know it looks really scary, and the first time it's always scary for patients, but they usually tolerate this surprisingly very well. As long as their pelvic floor muscles are not too tight. So if they have really, really tight pelvic floor muscles, then it's hard to actually get the needle where we need to get it. The other way that I also learned when I was in fellowship was fluoroscopic guided, where you're looking for the anatomic bony landmarks essentially, while someone is taking x-rays at the same time. And then that's when you position where you know where to position your needle near the ischial spine. This is usually the way the anesthesia pain clinics will do it. I typically don't do this anymore because I have had good success with the vaginal route. And of course, if we're doing it with fluoroscopy, there's always a concern for radiation and then also increased procedure time and cost. Some people will do it ultrasound guided. I do not do this, but Dr. Anatescu, who is one of our anesthesia pain docs, does do it with this kind of methodology. And then you can also do a CT guided block. And what I should mention is that all of these are typically done transgluteal. So meaning that the needle is coming through the buttocks to get to the area that it needs to be near the ischial spine. Whereas kind of when I do it in clinic, I'm doing it vaginally. So that usually also causes less pain. So our next topic that we're going to be discussing is vulvodynia. So vulvodynia is essentially vulvar pain of at least 3 months, and we don't really know what's causing it. So about 8% of women in the United States will suffer from this, and you know, some papers have quoted as high as 28% of women will experience this at some point during their lifetime. There are different types of vulvodynia, but there is kind of localized provoked vulvodynia, which we see a lot with patients who have pain with intercourse, and that's more, you know, common among women who are premenopausal. And then there's generalized form where they have essentially pain kind of completely around the vulvar vestibule, and that is more common in the postmenopausal. So in 2015, a group of gynecologic vulvar societies, essentially kind of ISVVD, ISHWISH, International Pelvic Pain Society, came up with guidelines as to how to classify vulvar pain and vulvodynia. And in general, vulvodynia, as you can see, has no identifiable cause. And so typically it is a diagnosis of exclusion, meaning that we need to diagnose all of these other possible causes, including yeast, herpes, lichen sclerosus, lichen planus, and you know, trauma. So sometimes like scar tissue or genital cutting, hormonal deficiencies, which you know that many of you are very familiar with all of Dr. Christmas's work. But we have to essentially rule out all of these before we can diagnose somebody with vulvodynia. And vulvodynia, like I said, can be localized, meaning that it is only located in a certain location of the vulvar vestibule, or it can be kind of all over the entire vaginal opening. And then there's provoked versus, you know, kind of constant. And constant vulvodynia is where you have the patients who tell you that even just sitting there feeling underwear against their vulva causes a, you know, irritative or burning sensation. And then, you know, for some people, it can just occur sometimes, like when they're wearing tight clothing, or for other patients, it occurs all times. It doesn't matter whether it's day or night, whether you're sitting or standing, they just feel a discomfort all the time. That type of vulvodynia, luckily, is much more. So evaluation. So once again, of course, we would do a detailed history. We'll do our physical exam that includes the musculoskeletal examination, because a lot of times patients are sent to me for vulvodynia, but they actually have pelvic floor dysfunction that's significantly kind of causing the pain around the vulvocavernosus muscles. And so then it seems like it's vulvodynia, but it's actually muscular pain. And sometimes both of them run together. So once again, you know, just because somebody has one thing doesn't mean that they don't have something else. But like I said, with vulvodynia, we do have to rule out other causes. And so oftentimes patients will have already had kind of testing for common STDs and have vaginitis swabs, but they oftentimes won't have a yeast culture done. And so I usually will collect a yeast culture if they haven't had one before, because sometimes you can have yeast that, you know, has not shown up positive on the vaginitis swabs or on the wet mount, that is actually present, and kind of doing a longer term course of an antifungal will help with the pain. Some people will do a vaginal pH to see if there's any significant kind of acidity that could be causing the burning sensation. And then, of course, you're going to do a detailed examination to see if there's any lesions. So do you see any kind of lesions that could be consistent with lichen sclerosis or atrophy that could be causing this discomfort? The other thing is that if you see something very, that looks abnormal, there are some kind of older literature that will recommend doing a colposcopy to kind of take a better look at the lesions. I usually do not recommend doing that because if you place vinegar solution, which is acetic acid, on the vulva of someone who already has a lot of pain, that can make that pain even worse. So I actually err on the side of biopsying a lesion if I think that there's any concern with a precancerous lesion. And then, of course, kind of the most important part of the vulvar exam when you're evaluating for somebody with vulvodynia is a Q-tip exam. So essentially, I will take the Q-tip and I will kind of go from 2 o'clock to 4 o'clock to 6 o'clock to 8 and then to 10. And I'll ask patients to kind of tell me where they feel the pain the most when I'm going around the vestibule. But before I do all of that, I will also kind of run the Q-tip along the thighs and then the labia majora and then the mons as well, just to make sure that they don't have any kind of significant pain in these other areas that could suggest a bigger kind of nerve issue or a different type of nerve entrapment rather than just the ones that we usually worry about near the vulva. The other thing is we'll also look to see if they have an anal wink sign with the Q-tip because that also tells us that kind of their motor nerves are intact. Most commonly, I will see pain from essentially from 4 o'clock to 8 o'clock. This posterior fourchette is usually the area that hurts the most. That's usually because that's where most of the pressure is when something is trying to be inserted in. So what are the treatment options? So of course, there's lidocaine ointment. There is, which, we oftentimes will prescribe because it's easily available. And the way that I prescribe it is apply lidocaine jelly to the opening nightly for 6 weeks. Now, some newer studies have shown that might not actually help, but because it's something that's easy for patients to do, and they can also use it as needed, like before intercourse or before, like if they have some sort of activity like working out or something, then they oftentimes will opt to try it. And then neuromodulators, once again, we do think that this is kind of due to abnormal nerve functioning. And so gabapentin, pregabalin, the tricyclic antidepressants can all help. If you feel like there is a muscle component to it, using some of the anti-inflammatories and the antispasmodics such as baclofen will help. But I try to do these because this pain is very localized just to the vulva. When possible, we try to use ointments to have less systemic side effects. And so I do use the compounding pharmacy quite a bit for my patients who have vulvodynia. And I will also sometimes prescribe a cream that we call like ABCDE or ABDE. You can essentially prescribe any component of that cream, but essentially it's a mixture of different medications that are targeting different pathways that can cause pain. So I have amitriptyline as my neuromodulator, baclofen as my muscle relaxant. C is capsaicin, which I don't oftentimes use because sometimes it can cause increased burning, but that is an option. D, diclofenac is an anti-inflammatory, and then E, estradiol, is estrogen because some patients can be a little bit hypoestrogenic, especially in that posterior fourchette area. As far as kind of non-pharmacologic, so essentially advising patients to kind of wear cotton underwear, to not kind of stay in wet clothing or sweaty clothing, using kind of organic hygiene products. Those are all potentially things that can help. Once again, physical therapy can help with the vulvodynia, especially with decreasing sensitization. For patients who don't respond to medications, I will do trigger point injections. Behavioral therapy has been shown to help as well. Very rarely will we consider a vestibulolectomy, which is essentially where we remove the vestibular tissue that surrounds the entry to the vagina. As one can imagine, that is, any surgical procedure always carries increased risks. And while vestibulectomy has been shown to be very helpful for patients with vestibulodynia, it does cause some scarring. And so once again, here's another algorithm that kind of goes over, the different things that we just talked about, and all the different treatment options. Okay, my last topic, and I know we're running out of time, so I'll try to get through it fairly quickly. So painful bladder syndrome, interstitial cystitis, oftentimes we will see this be treated by different specialties. So sometimes it can be treated by urology, urogynecology, and then pelvic pain specialists. But in general, it is defined as pain or urgency that is coming from the bladder of at least 6 weeks duration, and you have a negative urine culture and no identifiable cause. This is something that can affect both men and women, and affects approximately 2 to 6% of the general population, but it's much more prevalent among women, affecting about 6 to 13% of our female. So as far as evaluation, of course, detailed history, physical exam that include pelvic floor muscle evaluation. And the reason that pelvic floor muscle evaluation is really important is that oftentimes painful bladder syndrome or interstitial cystitis is actually caused by muscle spasms of the muscles surrounding the bladder. It makes patients feel like they need to urinate a lot and can cause irritative bleeding symptoms. And so if you find that a patient who has kind of high tone pelvic floor dysfunction is complaining of what is considered interstitial cystitis, once again, physical therapy might be the answer that they need. The other thing is that we want to make sure that we rule out kind of urinary tract infections. So we get a urinalysis, urine culture. We also want to see if these patients are retaining urine. So we'll get a post-void residual. We will recommend that they keep a bladder diary so that we can see if there's any kind of behavioral modification that we could make to decrease their discomfort, and also to see if there are any specific triggers, especially food triggers. And then, we don't have to do a cystoscopy, which is where we look inside the bladder for every patient who suspect to have interstitial cystitis. But if they do have blood on their UA, or if we're concerned about Hunner's ulcers, which is kind of a very severe erosive form of interstitial cystitis where patients will form ulcers in their bladder, then that's when we do consider a cystoscopy. So what's the treatment? So kind of first line treatment is bladder diet and physical therapy. And the bladder diet is essentially something where they are avoiding a lot of foods that usually increase acidity inside of the bladder. So things like tomato sauce, citrus, chocolate, coffee, caffeine. Those are all, unfortunately, things that patients have to eliminate from their diet. Now, what I usually tell patients is they don't have to eliminate everything, but if they eliminate one thing each week and see which one helps their symptoms the most, then we'll know kind of what foods trigger them, and then they can just avoid those in the future rather than kind of avoiding everything on the sheet. Tricyclic antidepressants like amitriptyline or triptyline have shown to be very helpful for patients with painful bladder symptoms. Antihistamines such as cimetidine, hydroxyzine have also been shown to help with interstitial cystitis. And then one of the few medications that's actually FDA approved for interstitial cystitis is pentosan polysulfate, or PPS. When I was a fellow, we used to use that quite a bit for treatment of patients who have interstitial cystitis. However, that has fallen out of favor because it can have one of the side effects that they have found out more recently, and is that it can cause potentially retinal detachment. And so we don't use it as often anymore, more just for our refractory cases, as long as patients understand that. Another, thing that I offer in my clinics that are equipped to do so are bladder installations. So this is something where we essentially instill a mixture of different medications into the bladder directly by backfilling the bladder. And so that usually is heparin, lidocaine, and dimethyl sulfoxide. And we kind of put that in, and then we ask patients to hold the solution in their bladder for about 1 to 2 hours if they can, so that the medications have time to kind of absorb into their bladder mucosa. And then they can release, and they do these installations weekly for 6 to 8 weeks. And then after that, typically they'll feel a difference in their symptoms, and then they can just come back as needed for installations. Once again, we can do trigger point injections. We can also consider bladder Botox, especially for patients who have urgency that is not responding to kind of any of these more conservative treatments. We can consider also a bladder hydrodistension, which is where we take patients to the operating room or under sedation, and we kind of look inside their bladder and then fill it to a kind of moderate to kind of high amount for a few minutes. So there have been studies looking at kind of short hydrodistension and prolonged hydrodistension, and we prefer short kind of time periods of hydrodistension, so just a few minutes to essentially kind of stretch out their muscles, help relax them, and then we empty the bladder and then see how they do. And this is done under sedation because distending the bladder, especially for somebody with interstitial cystitis, can be quite painful. And then for our refractory cases, we can consider a sacral nerve stimulator such as InterStim that are a urogynecology and anesthesia pain columns. Kind of just parting. So in general, behavioral health is very important to the treatment of all of these conditions. So pain decreases quality of life, and it can cause depression and anxiety. The converse is also true, right? If you have depression and anxiety, sometimes you feel like you have more pain. And many patients who have chronic pelvic pain do suffer from PTSD, and that automatically causes tightening of muscles kind of throughout the body, but especially in the pelvic floor, depending especially on what type of trauma someone has experienced. So it's always important to kind of get a baseline for where patients are in their mental health. A lot of times patients, if we bring this up right away, will think that we think that everything is in their head. And I always tell patients that, I know that their pain is real. And I just want them to kind of get multidisciplinary care where we are essentially addressing all facets of essentially all facets that could be contributing to their pain. And so that includes kind of nutritional well-being, emotional well-being, of course, kind of physical well-being, and then of course treatment for that actual condition. But there are many studies that have been shown cognitive behavioral therapy helps with, pain. EMDR will help with PTSD. We have pain psychologists we can refer our patients to. A lot of patients who have these conditions really suffer from poor kind of relationships with their partners. And so sex therapy and couples counseling can be very, very important for these patients. And luckily, we offer both at University of Chicago. Then, of course, for all of you, how can we all help each other? So, for the medical assistants who work with me, they know that a lot of patients may feel uncomfortable with some of the questions that we have to ask during our normal screening. Our patients are going to be at high risk for screening positive for depression and for abuse. I always ask my MAs to not ask my patients to undress because they may not want to undress at all during the appointment, but we probably definitely don't want to do it before they talk to me and make sure that they understand kind of what their care will be like. I always have a chaperone with me during my clinic appointments. The chaperone serves, kind of multiple purposes. It helps me get through the appointment more quickly, especially with these exams that can be very traumatic for our patients. But also sometimes our chaperones serve as support people for my patients. They will sometimes hold their hand if they're nervous. So all of these are the kind of things that our medical assistants and also sometimes our nurses can do as well. As far as our nurses, my pelvic pain patients oftentimes have a lot of in-basket messages and calls. This is due to kind of underlying healthcare anxiety. And so if, they have if you feel like they're having excessive questions or calls, just schedule a follow-up appointment with me or whoever their provider is, so that we can address those in more detail. I don't want anybody to feel overwhelmed, but it's just, these patients just, have a lot of medical distress sometimes. And so it takes time for them to kind of understand how everything works. And then of course our nurses prepare our injections and our bladder installations, and they oftentimes also serve as a chaperone, especially for procedural appointments. Thank you so much. I know I went a little bit over time, but I'm happy to take questions now. If anybody has any, here are some references.
You're getting lots of love there.
I was like, I can't read. I'm like too scared to touch anything now on my screen.
No, yeah, there's no one's, there's some hearts that went up from Tatiana. There's a thank you from, I don't know what CN is, from CN to everyone.
Crystal, that's Crystal.
Oh, hi, Crystal, thank you. No, I think, this is a really hard topic, right? And just because, and it's really complicated for patients because they are so miserable and they've been dismissed a lot by the healthcare system and previous, healthcare professionals that they may have seen. And, our medical assistants and nurses are literally first line. And often, the first face that the patient is going to encounter when they come here. So it is really important, as Dr. Patanwala said, to make them feel comfortable. And and you all know, I say just the opposite. I want all my patients undressed because I'm moving so fast. But just being very conscious of patients coming in. And they probably are snickering, Dr. Patanwala, because I said I'm moving fast, but it doesn't seem like it because I'm always 2 hours behind. But at any rate, in my mind, I'm moving fast. But I do think just giving them those pointers on how they can help, and because they are so important to your being able to care for the patients. But even though they need a little bit more hand holding, it's really important and helps to validate their care, especially because they may be asking them questions about things, and you answered everything so eloquently. So hopefully, guys, please ask questions. If there's stuff that the patients are asking you about and you're always like, I don't know how to answer this, or, I don't know what a bladder installation is. How am I going to tell them if they need it or not? Please chime in. Or it might have been Dr. Patanwala that you were so thorough that they don't need to ask the question.
I mean, this is always a difficult topic. It's not something that we're truly doing in all of our clinics, and I always feel bad for our amazing nurses if they have so many providers who they have to manage and remember what they need to do for each person. So I do appreciate all of your flexibility and your help in caring for our patients.
All right, I guess she did an amazing job. Someone said this was really helpful. It was Patasha. It really was. So thank you so much. Really, really appreciate it. Good night, everybody.
Thank you. Good night.
Thank you so much for joining us.